Our second speaker is Dr. David Murdoch. David's work focuses on HIV and inflammation. His early work focused on TB-associated immune reconstitution inflammatory syndrome in HIV-infected patients in South Africa. In addition to infection-related inflammation, his work has also spanned domestically, investigating the role of inflammation in non-communicable pulmonary diseases in HIV patients, including tobacco use and asthma. With Christina Mead of the CFAR SBS Corps, he is the recent recipient of an R01 investigating the role of immune activation and inflammation in neurocognitive impairment in HIV-infected substance abusers. Today, he will present his recent work describing the prevalence and phenotypic characterization of asthma in HIV-infected patients. David?
Thank you. I guess not. Okay. No, let me see. No, it's not. Okay. Okay. Thank you for allowing me to speak, and I'm really standing up here for a much larger team who really made all this work possible. This work was out of a grant that John Bartlett and Monica Kraft, when she was here at the time, obtained as PIs, and Loretta Quay has been really been the gelling force for this and pushing forward a lot of this work. And what I'm presenting here was a lot of work that was done in a short period of time, and I hope to sort of take you through what we were able to accomplish and where we aim to go. So HIV and asthma, basically non-communicable diseases, as you probably know from many of the RFAs and a lot of the focus now, are really a major focus right now in HIV-infected patients due to just the sea change in ART and how we approach management these days. And what has been known is that a lot of work via Crothers and Alison Morse and other people is that COPD, it tends to be the most focused on condition here. And we know that HIV patients suffer from high rates of obstructive lung disease. They also have incredibly high smoking rates. But outside of that, they have increased respiratory symptoms out of proportion to that measured lung function. And we also know that mechanistically, they appear to have an accelerated form of COPD, emphysema, and obstructive lung disease. But outside of epidemiological work, much less is known, and even less is known about asthma. As I said, most of the focus so far has been on COPD. So why is that? Well, we know that HIV is associated with a decreased pulmonary diffusion capacity. This is one of the measures that we use in lung function studies to measure oxygen exchange in the lung. And this is more recent work that has started to get more mechanistically. You can see in the literature where others have noted that GP120, when they expose bronchial epithelial cells to this antigen, they note increased mucus production, at least in an in vitro assay and test, and this seems to be CXCR4 mediated. Interestingly, in some pathological specimens, both in human and in macaque models, within the pulmonary small airways, they also note increased mucus production. So there's this sort of appreciation now that there's a much more immunological and antigenic interplay between HIV and diseases such as asthma. And when you start talking about non-communicable diseases and immunology and non-communicable diseases, most of what has really been appreciated recently is the correlation of IL6 in cardiovascular disease and all-cause mortality in HIV infection, and a lot of this is driven by some of the really stark learning process of structured treatment interruption and those trials that came out now several years ago. IL6 has been called a sort of keystone cytokine. And in fact, if you really look at the sepsis literature, the obstructive sleep apnea literature, even some of the neuro literature, IL6 always seems to be, elevated and a player. But is it reactive or causative is much less known. It is likewise being associated with increasingly with asthma pathogenesis. It promotes IL4 production during Th2 differentiation, and it's expressed pretty highly in lung epithelial cells and, of course, monocytes and macrophages as well as sort of very potent producers of this cytokine. So it's been one that's, outside of asthma and others, very noted to be involved in pathogenesis. And so borrowing from that cardiovascular and HIV literature, we proposed and thought that this might be a pathogenic mechanism in asthma, especially with the increasing recognition of it in non-HIV associated asthma. So why do we even want to go down this road and talk about asthma and HIV? Well, I mean, it's a pretty prevalent disease. I'm sure maybe some of you in the room even have it, given that it's about a prevalence of 7%, or know somebody who has it. So we give a bunch of inhalers, most of them corticosteroids, and people are managed and get better. So why even go down this road? Well, it's given that it's an immunologically driven disease, it's increasingly recognized as pretty heterogeneous. And even skeptically sort of looking at this, it's pretty easy to recognize that it is so. We have what we call phenotypes or subphenotypes or endotypes of asthma now, and distinct ones are obese asthma, which tend to be very steroid resistant and mediated by different inflammatory profiles. And we'll get into a little bit of this in a bit in terms of sputum differentials and whether it's an eosinophilic or atopic or a neutrophilic-driven disease. We see variations in responses to inhaled corticosteroids clinically, differences in response to triggers, and the cellular inflammatory phenotypes are also quite mixed. And people can be classified now, we think, into sort of an eosinophilic, neutrophilic, and mixed cellular phenotype. And then within molecular phenotypes, people have described Th2 high, Th2 low. And really, when you start looking at some of the more recent literature and trials, you come to appreciate that a lot of this has some basis because we're now developing anti-IL5, anti-IL13, 4, all of these sort of very conical Th2 cytokines, and some of these are in various states of clinical trials and approval. But the one we do have is an anti-IgE or Xolair, and you may have heard or probably seen commercials for it. And that's clinically approved and has is clinically approved essentially for a particular asthma phenotype. So when we talk about why do we want to go down this immunology road here, when you start considering that you're layering on, HIV and all of its immunological derangements along already on top of an immunologically driven disease, it takes some characterization to discern through this, and it's probably warranted. So we set out to first determine, the prevalence of HIV-infected patients with asthma. So unlike COPD, we knew much less. Most of the studies, and epidemiological studies at least, were conducted with very male-predominant cohorts, such as VA cohorts. And then, doing this in the Southeast, where we have sort of what people have called the more modern picture of HIV infection in the rural areas and high prevalence of African Americans, also who have a lot of who have a high prevalence of asthma itself. Certainly a driving force to sort of, look at this here. And of course, we wanted to, phenotype these patients, which really sort of carefully and prospectively and cross-sectionally had not been done. And we performed both clinical and physiological phenotyping and immunological phenotyping, and I'll try to get through this. So one of the first things, or one of the projects that we were doing, and there's of course a poster outside that Loretto put up for our fellow Devin, who couldn't be here because he's in Africa doing some similar work, was we developed both HIV algorithms, 2 algorithms that were based on lab studies, medication histories, and ICD-9 codes. Of course, with EPIC coming online now, this is, of interest to a number of different diseases and how you go through this and develop these algorithms and extract this information from our data systems. And we also looked at using a bunch of asthma algorithms, and these are sort of the 4 or 5 that have been published, and Isorette O'Reilly in our division had been working with quite a lot with her STEADY cohort. And so we were able to sort of take these 2 algorithms and put them sequentially and sort of get an idea of what the prevalence is in this population. Then in terms of clinical and physiological phenotyping, we did EMR data abstraction. The ACQ is asthma control questionnaire, and SNOT-22 is a sinus questionnaire, which assesses those symptoms, as well as we did full pulmonary function tests, methylcholine challenge, measurement of exhaled nitrogen, NO, and Fadia top testing, which looks at atopy. Immunological phenotyping, we drew the whole gamut. We did 23-plex cytokine analysis and flow cytometry using some standardized HIPSI immune profiling assays. So quickly, results, trying to measure through this. This is sort of a very busy table here. But what this is presenting here on the left side are essentially the asthma algorithms that we ran through, of course, with Ben Neely and folks who are in the statistics department who really excel at sort of using these methods and algorithm methods, as well as the HIV algorithm, and looking across sort of all the patients in our EMR, right, or these huge databases. And the take-home point here is that when you look in the HIV uninfected population, our algorithm and the use of these algorithms and how we approached EPIC and the EMR estimated the prevalence of asthma at 4 to 6.8%, which is reassuring because local other Medicare data shows that it's 6.8, and generally the prevalence is around 7%. So somewhere between 5 and 7%. So our algorithms proved to be very accurate in that regard. So then, how do they perform, or what was the estimate in the HIV infected population? Our suspicion was higher, basically because you have the target population as well as just anecdotally and clinically. There's a bit more of a wider range here in terms of the estimates, but we estimated that actually in this population it's more on the order of around 9% to 10%. So we do think that it's elevated in prevalence, and this was sort of one of the whole goals of the project, was just to answer how big of a problem with this is this. And we think that it is at least a bigger problem, if not more. And there's also some caveats with the clinical management, which sort of put what might be a very small difference into an important context. So clinically, what did we do? Well, we were able to, essentially in 7 months of recruitment, phenotype 29 patients and 29 HIV infected patients with asthma identified as with asthma, and 33 uninfected. Overall, there's a lot of numbers on there, but they actually had very similar clinical and asthma characteristics, including lung function as measured by an FEV1. This is a lot of the measures that we do, and I won't go into exactly all the normatives of these and what these measure, but basically lung function was very similar between groups. One difference we did have was that more females were recruited into the HIV that you can see in the HIV uninfected group. We had a disproportionate amount of females. And the only other difference sort of clinically that popped out was that, and this is important when we start talking about the immunological data, is that within the, the HIV uninfected group with asthma, they actually had higher usage of inhaled corticosteroids, which is important when we start talking about the immunology, right? But this really sort of ICS, or inhaled corticosteroid, and a long-acting beta, this group here, is a very, very routine and very standard therapy in asthmatics. And interestingly, within the HIV-infected patients, we did not see as high a ICS and a combined LABA usage, which, I think if we delve deeper, will, similar to the data on malignancy and chemotherapy, just points to some of the differences in management and access to pulmonologists. But the take-home point here is that at least clinically, most measures, they were very similar. There was a trend, almost significant, moving towards significant here in the differences in asthma control, or the ACQ score. 1.6 is high. It doesn't look like much, but essentially 1 or less denotes good asthma control. So this was higher in the HIV infected group, which might correlate with some of the differences in inhaler use that we saw. So immunophenotyping. So we ran sputum inflammatory profiles. These differed significantly. Namely, both percentages of eosinophils was higher in the HIV-infected group compared to the uninfected group, as well as in sputum neutrophils. You can see the HIV-uninfected group had more of a neutrophilic predominant sputum profile. And there were also differences in 8-isoprostanes, which is a biomarker of oxidative stress in the lung. So immunologically, we both did serum and did induced sputum and looked at cytokine profiles within both compartments. I'll tell you, peripherally, these patients were on ART. So actually, cytokine levels were, for all the 23 markers we did, were non-significant between the groups. There were a couple that were elevated a little bit in the monocyte lineage, which I'll get into in a minute. But most of the signal, if you will, was really in the lung compartment, which would be what you'd expect, right? With asthma being a lung-specific disease. And a bit to our surprise, IL6 was notably elevated in the HIV patients within their induced sputum in the lung compartment, as well as CXCL11, TNF-alpha, which is, I don't have to explain that to a lot of people here in the group, and MIP3-alpha. So some markers of monocyte activation and T-cell T-cell migratory adhesion. And this, we actually did not see any elevations in the sort of classical cytokines of IL-4, 5, and 13, which are typically associated with asthma, curiously enough. And then in the periphery, the main one that popped out, which has a lot to do with some of the HIV literature, is soluble CD163, which has been noted also in cardiovascular outcomes and a range of HIV and non-HIV diseases. We did not see any difference in soluble CD14, which has been noted previously to correlate with some COPD severity and severity of disease and other non-communicable diseases. So in summary, it looks like, at least in our cohort, HIV asthma appears, HIV infected asthmatics demonstrate a phenotype that, at least by our sputum measures and other measures of inflammatory profiles, tends to be an atopic and more of an eosinophilic phenotype. Now, this use of inhaled corticosteroids could be a very significant and modifying factor there, where we do see differences in the groups, and needs for further control and investigations. We do think that there's, just based on the 8-isoprostanes and other cytokines that we're seeing there, suggestion of increased pulmonary oxidative stress in these patients. That might also have to do with the poor control and the ACQ, and again, the inhaled corticosteroid use. And what's interesting, at least a bit more unexpected from my standpoint, of course, usually focused on T cells, is that most of at least the cytokine profiles that we analyze, there's a bit more of a suggestion of the monocyte and macrophage activation rather than so much of a T cell activation. And this actually correlates with what WADA published last year in AIDS, where they looked at very long-term cytokine profiles in patients on ART for multiple years. And the ones that remained elevated quite long into ART were those of more of suggesting monocyte activation. So it's very interesting. And then sort of the more then you delve into asthma, there's a lot there too. So there's M1, M2 macrophage activation, which is what they suggested. And their markers that remained elevated were CXCL10 and some of these others, including IL6. So there's certainly some interesting results here that we aim to take forward. Now, limitations, obviously, we don't have any, at this point, non-asthmatic HIV controls. We are rectifying that with a voucher grant that we're going to recruit some additional patients to answer this question. Well, IL6 is up, yes, and CD163 is up, but those are also up just in the context of HIV. So is it really asthma that's powering that, or are you just measuring this in HIV patients, which is a valid point and criticism that we aim to sort of hope to answer with additional recruitment. And again, I mentioned the gender and ICS distribution. We will recruit additional controls. There's a lot of sort of flow phenotyping that we have to, once these controls are done, analyze and look at too. We have a whole sort of at least peripheral profiling done in these patients, and we're seeking additional funding opportunities. We got a fairly good score on our resubmission, but not quite fundable, but we've really just in the course of this, realize there's really so much to do, and really what we've done here is really pretty unique. So I'd like to, first of all, thank the study participants. Loretta has been really the galvanizing force behind this. I would say also that this arose out of the symposium that Mary Klotman put together. Was it 3 years ago now? Jesus. And just gelling this idea and coming together with John and Monica Kraft when she was here, and of course Mary being on the ID side, really our champion there to get this done. Devin Paul really put a lot of work into the algorithm and all the outcome stuff that I presented early on. There's this poster out there. And then we had really quite a big team to get this done. We got all this done, so recruitment, immunology analysis, and the grant rewritten in just over a year, which shows that if you have enough people and you push hard enough, you can get things done. So Rithi, and both Ali and Rithi have moved on. Amber as well, but they were all a real part of that core team. Izaretta for the algorithms, Ben and Joe on the stat side, and as well as Matthew, and then Najir. We had a bunch of pulmonary colleagues who were actually able to push this forward too, and then the clinics as well. So that's it.
Questions for David?
Yeah, so I know you showed how your two groups were similar to each other, but if I read it correctly, you had a whole lot more cigarette smokers in your HIV-infected group. The difference wasn't quite statistically significant,
Right.
but it was close. And if you just look at proportion, it's a lot more. So how do you know that these differences that you're seeing in the two things are driven by HIV versus cigarette smoking?
So there were no current smokers. These are ever smokers. And we really focused on that, just knowing that the prevalence in these folks is like 70%, right? So no current smokers. So these were people who had smoked in the past.
That was just past smoking.
Yeah. And if you look at their ever pack years, their total pack years, like a 4.8 pack year history is pretty low. And we generally approach anything who have 10 or above. That's when you actually start seeing pulmonary-wise physiological changes in sort of obstruction and pulmonary function testing. So that was one of our very close, exclusion criteria, and but this group, to find non-smokers is very difficult, but we were able to say not current and certainly less than 10 pack years. So 4 is about pretty minimal.
And smoking, did you only count cigarettes or smoking other substances?
Well, good question. Cigarettes mainly. They're also high prevalence of marijuana usage, and abstracting that data is very, as you know, it's a big challenge. So certainly something we would obviously continue to focus on and in our additional recruitment as well. So, yes.
So recently there was a study that showed omega-3 fatty acid derivatives have played a role in clearing a common bacteria that's found in COPD patients. So I was curious if that could be something to study in this cohort of patients that have COPD and HIV in the context of maybe the fatty acid derivative can counter GP120 in some aspect.
Yeah, there's a lot of neat mechanistic things we could do. Interestingly, there's a good deal of work with, Monica Kraft had done a lot of this too with mycoplasma and asthma, and we certainly see a lot of, co-infections and other infections in COPDers, including viral infections. So there could be a lot that we could do mechanistically. And I think this has really helped sort of at least paint the picture of what we're sort of clinically and broadly immunologically approaching. But yes, some of that stuff would be really interesting to do. And there's some animal models that exist, of course, for asthma and so forth that we could pursue some of those ideas. So
thank you.
Welcome.